Hello and welcome to Boundless Dentistry. In this video, we'll talk about a very important condition in dentistry, which is called as oral submucous fibrosis. Now, this condition in terms of dentistry is very important because this condition affects the person's well-being entirely. So, in this video, we'll talk about introduction, etiology, pathogenesis, clinical features, investigations, grading, staging, management, and then finally talking about complication. If this disease is left untreated, how it can further deteriorate the condition of the patient. So let's get started. Now, starting with introduction, oral submucous fibrosis is a chronic condition and it is potentially malignant as well, which we'll talk about later in the video. But to begin with, this is a chronic condition in which primarily there is excessive deposition of collagen in the connective tissue. As the disease progresses, there is increased fibrosis, and that fibrosis eventually leads to the most important symptom of this disease, which is called as trismus. Now, in normal individuals, if we measure mouth opening from the incisal edge of upper teeth to the incisal edge of the lower teeth, normally it's about 30 mm, which is normal mouth opening. But in patients with OSF, oral submucous fibrosis, because of excessive deposition of collagen, mouth opening gets limited, and in patients who are suffering from or possibly suffering from OSF, the mouth opening is limited, which means it is below the normal values. So as you can see in this diagrammatic representation, if you compare with this and this, you can see that the mouth opening is now limited. So now, if we talk about the epidemiology, OSF is mostly found in the South Asian countries, and the reason here is that excessive consumption of betel nuts. Now, this betel nuts leads to increased irritation, or simply put, increased irritation of the mucosa all around the mouth, and that leads to increased inflammation, and that inflammation leads to excessive fibrosis. Now, if we talk about gender distribution, OSF is mostly found in males as compared to females. Furthermore, it is most commonly associated with young adults. Now, moving on towards the etiology and pathogenesis of OSF. OSF is a multifactorial disease. It has two possible causes. Either they can be local causes or they can be systemic causes. Firstly, we'll talk about the most important and almost always is associated with OSF is the local cause, which is areca nut. Chilies have also been associated, but the evidence is less conclusive as compared to consumption of areca nut. If we talk about systemic causes, we have nutritional deficiencies, sometimes genetic, and very rarely autoimmunity can also lead to OSF. Now, we will focus in this video in areca nut because almost always 90% or more than 90% of the cases of OSF are associated with consumption of areca nut, which the patient gives us the history of areca nut, and that eventually leads to OSF if this habit is not stopped on time. Now, areca nut has a substance which is called as ericoline. This ericoline leads to fibrosis, and that fibrosis is responsible for rigidity and limited mouth opening. Now, if you go further into detail as to how ericoline affects the limited mouth opening and leads to OSF, ericoline is a substance which further has a molecule which is called as ericidin. Now, ericidin leads to increased fibroblastic stimulation and proliferation. Now, these fibroblasts then leads to increase in collagen synthesis. Now, these collagen synthesis then promote fibrosis. Furthermore, in areca nut, we have tannins. Now, these tannins are responsible for inhibition of collagenases. These are those enzymes which are responsible for the degradation of collagen. But since these enzymes are damaged, or you can say inhibited, so there is decreased collagen degradation, and which leads to increase in collagen production, because normally the collagen production and collagen degradation is balanced out. But in cases in OSF, when patient is consuming areca nut, this ericidin then leads to decrease in collagen degradation. Now, together ericoline and tannin leads to the final end product, which is called as increase in collagen production and decrease in collagen degradation, which eventually leads to fibrosis, which is the culprit, or you can say the final process which leads to limited mouth opening. Now, As I've mentioned before in this video, at the beginning of this video, OSF is a potentially malignant condition. It can lead to cancer, which is oral squamous cell carcinoma. Now, if we talk about the mechanism as to how this occurs, initially ericoline is present. Now, ericoline inhibits this enzyme which is called as P53. Now, P53 is one of the most important tumor suppressor genes which is present, which basically regulates the cell cycle throughout the body. Now, since ericoline inhibits this P53 enzyme, the cell cycle is now arrested. There is no check and balance to the cell cycle. This further leads to suppression of endothelial cell population, and it leads to atrophy of the epithelium and hypoxia. This injury, or you can say insult to the epithelium, then promotes carcinogenesis, and then eventually this OSF condition, which was initially a pre-malignant condition, now it can be leading towards development of oral squamous cell carcinoma. This was all about etiology and pathogenesis of OSF. Now, moving on further along this video, now we'll talk about clinical features. Now, about clinical features, one of the most important features, as I've already told you, is patient suffering from trismus. But there are other symptoms as well, which starts when the patient initially begins to complain of burning sensation in their mouth, because as the areca nut is irritating the entire oral cavity, there will be some burning sensation complaints by the patient. Next, some patient can also complain of blisters in their mouth. Secondly, excessive salivation. Now, the reason for excessive salivation is that since the areca nut, which is consumed mostly and that eventually leads to OSF, this areca nut irritates the entire oral cavity, which leads to excessive salivation just to combat the excessive inflammation that is occurring in the mouth. Next, xerostomia. Xerostomia is also a common feature in patients who are suffering from oral submucous fibrosis. Now, blanching of mucosa is a clinically important sign that is found by the dentist because there is increased fibrosis. Now, this increased fibrosis then leads to obliteration of blood vessel, which basically is giving the oral mucosa its reddish or pinkish color. So since there is excessive fibrosis, when a dentist stretches the mouth of the patient, it leads to whitish discoloration of the oral cavity. As you can see, this white appearances, you can see this is the blanching of mucosa, which is very important sign in patients suffering from OSF. Another clinically important sign, which is distinguishing feature that the patient may or is actually suffering from OSF, is the white fibrous bands. As you can see in this clinical picture, these bands around the tonsillar pillars, as you can see, anterior and posterior pillars, also around you can see retromolar pad area, palate, all around these areas you can see there are white bands, and when you palpate it, they're actually very hard because of excessive fibrosis. So this is an important feature, white fibrous bands, which you can also clinically see. Now, since there is excessive fibrosis over here, they become really hard. So when they become really hard, they have an action on the uvula, that they stretch the uvula in the left side and the right side, which can make the uvula appear either shortened or slightly deviated, depends on which side fibrosis is excessive. For example, if fibrosis is excessive on the left side, the uvula will deviate towards the left side and vice versa. So that is also an important sign. Now, impaired tongue movement because of excessive fibrosis are occurring around the entire oral cavity. Now, as you can see in this clinical picture, the mouth opening of patient is very much limited. Only 2 fingers are normally going inside the patient's mouth. Normally in normal patients we have at least 3 fingers going, but in the patient, this patient, OSF patient, you can see there are only 2 fingers going. So there is limited mouth opening, and since this patient cannot open his or her mouth properly, there will be difficulty in whistling or blowing. And also importantly, patient will have difficulty in eating as well, because for example, a patient is trying to eat a burger. That burger will be very large for the patient to open its mouth. So that will be a difficult thing. Patient will mostly be on liquid diet or soft diet or that sort of diet which does not require excessive or even normal mouth opening, because in these patients this is not a normal mouth opening, this is a very limited mouth opening. So this was all about clinical features of OSF. Now moving on towards the histopathology, mainly OSF is diagnosed with clinical features along with the histological examination as well. So we'll talk about histopathology. Firstly, the histopathology or histological changes of mucosa. depends on the disease severity. The more severe the disease will be, the greater the histological features we can appreciate. Now, initially there is normal mucosa, there is no irritation around the mucosa at all. Now, when the disease starts to progress, it will lead to atrophic mucosa, and then eventually it can lead to hyperplasia of the mucosa as well. Now, if we talk about atrophy, atrophy will lead to increased cellular intracellular edema. There will be some signet cells, and then maybe some focal dysplasia, because these are the region where there are chances of cancer cells to develop. Now, we can also appreciate, as you can see this histological slide, there is increased pinkish appearance. You can see this is increased keratinization. Sometimes, as you can see, there are more purple nuclei visible over here. This can give us an idea that maybe there is some excessive mitotic activity. Next, blood vessel. As you can see, we can hardly appreciate any blood vessel over here, but in patients, these blood vessels are either dilated or congested, and in severe cases, these blood vessels can also be obliterated as well. In this diagram, you can see these are how blood vessels normally appear. This is a diagrammatic representation. This gives us an idea in histological pictures where we can appreciate blood vessels or not. Now, polymorphonuclear leukocytes, they will also be excessive in number initially, but as the disease will progress, there will be more lymphocytes and plasma cells. In late stages, there can be some melanin deposition as well. There is increased hyalinization and decrease in number of cells. Hyalinization is basically a very important feature in OSF, where there is conversion of stromal connective tissue into homogeneous acellular translucent material. As you can see how the oral cavity appears when the patient has OSF. Now, as the disease becomes more severe, all of these features, as I've listed right now, they increase in their severity. The severity increases of these histological features. This was all about histopathological features. Now, if you talk about investigation as to how we can reach a eventual diagnosis or definitive diagnosis that the patient is actually suffering from OSF, firstly and the most important thing that we can do to confirm our diagnosis is the gold standard biopsy. This biopsy undergoes histopathological investigation. It lists and goes through all of the histological features that we have just discussed, and this gives us a definitive diagnosis that yes, the patient is or not actually suffering from OSF. Now, histopathological features is one thing, and then we also correlated with the clinical features, because both of these features then gives us an idea that either the patient is suffering from OSF or not. Other than that, we also go for CBC to get an idea of the general health of the patient. Sometimes iron levels and B folate, B12 and folate levels as well, because as we have talked in the beginning, sometimes nutritional deficiency, although rare, can also lead to OSF. Now, next, we'll talk about the differential diagnosis. There are some conditions which can mimic in clinical appearances as they look familiar to OSF. We have to rule out these conditions. Firstly, we have scleroderma, amyloidosis, anemia, fibroma, generalized fibromatosis, and leukopenia. These are some certain conditions that we have to eliminate so that we can reach a definitive diagnosis of OSF. We have to exclude. Now, how do we exclude these? We exclude these on the basis of firstly biopsy, and that biopsy along with clinical findings. Both of these features then help to reach us a definitive diagnosis of OSF. The severity of OSF can be either staged or graded. Now, staging is mainly on the basis of clinical features of the patient. However, grading is mainly on the histological features. So first we'll talk about staging. Now, there are two types of classification that we can use. There is functional mouth opening classification and there is clinical classification. Firstly, we'll talk about functional mouth opening classification. Now, in the beginning, we talked that how do we measure the mouth opening? Like we get an estimate of the mouth opening of the patient. We measure it from the incisor ledge of the upper maxillary central incisor and to the incisor ledge of lower central incisors. Now, stage 1 tells us that maybe the mouth opening is less than 30 mm but greater than 20 mm. Stage 2 tells us that the mouth opening is between 10 to 20 mm, between that. However, stage 3, which is the severe stage, mouth opening here is less than 10 mm. This is the first classification that gives us an idea how much the trismus has affected the oral cavity or mouth opening of the patient. Second classification, the clinical classification, is that now in stage 1, initially the patient will have stomatitis, that is increased inflammation around the oral cavity, and some blanching as well. Blanching is when you stretch the oral cavity or the buccal mucosa by your hands, there will be whitish appearance. Normally it's pink in appearance, there will be whitish appearance. In stage 2, we have palpable fibrous bands. As you will, for example, a dentist chooses to examine the patient's mouth. When we will try to stretch the oral cavity or the buccal mucosa, we can actually feel some hard bands as well around the buccal mucosa, and these fibrous bands can also extend to the oropharynx with or without stomatitis. Now, if you talk about stage 3, there will be palpable bands. Now, the bands have now increased in their localities. They will be in buccal mucosa, oropharynx, and along with that, other parts of the mouth as well, with or without stomatitis. In stage 4, there are two types of stage 4, 4A and 4B. In 4A, there will be any of the above features, all of the features will be that, along with leukoplakia and erythroplakia as well. These are the pre-malignant conditions which affects the oral cavity. Patient can have that as well, and that means that now the patient is at risk of developing oral squamous cell carcinoma. And then in stage 4B, now the patient has any of the above features. Along with that, patient now has oral carcinoma as well. So this is how we stage on the basis of functional mouth opening along with clinical features as well. Now, another way to classify OSF is on the basis of histology. That is called as grading. We have 4 grades we can perform using histological slides. Now, in grade 1, there will be fine fibers and there will be edema as well, slightly. In second feature will be increased fibroblastic stimulation. Blood vessel, however, they will appear normal, and there will be polymorphonuclear cells. This is grade 1. When we talk about grade 2, all of these features will now be increased. There will be increased, or there will be early helionization. There will be increased fibroblast. Now, blood vessel will either be dilated or there will be congestion, mainly because of fibrosis. Now, lastly, there will be lymphocytes and some plasma cells as well. When we talk about grade 3, now there will be more collagen fiber will be helionized. There will be increase in fibrocytes. Now, the blood vessel either will be constricted or sometimes they can appear normal as well. And lastly, there will be increase in lymphocytes, plasma cell, and inflammatory exudate as well. And lastly, if we talk about grade 4, in grade 4 there will be complete helionization of the collagen fibers. There will be no fibroblast. The blood vessel will be either narrow or completely obliterated, and there will be increase in lymphocytes and plasma cells. So this is how we grade OSF on the basis of histology. Now, so far we have talked everything about OSF in terms of its etiology, pathogenesis, how do we check for clinical features, definitive diagnosis is now reached that yes, patient is suffering from OSF. Now, what are the different treatments we can offer the patient in order to help them live a better life, if not completely curing them of OSF? There are 7 approaches that we can take. Firstly and most importantly, this thing which is restriction of habits like consumption of betel nuts has to be stopped, because if this is not stopped, any of the treatment will not work on the patient. Firstly, restriction of habit. For example, we have to restrict betel nuts because that is the main culprit of causing OSF. Secondly, smoking is also to be released. Smoking should also be restricted, or it will be preferable if there is complete cessation. Secondly, since there is increased inflammation and fibrosis, we can give patient corticosteroid. This leads to decrease in inflammation, decrease in fibrosis, and it can be given in the form of local injection and mouthwashes as well. Since there is increase in helionization, we can give hyaluronidase. This can be given in intralesional injection, which will lead to decrease in collagen formation, which is very important for us, and it will lead to breakdown of hyaluronic acid as well. This will help to treat the patient who are suffering from OSF. Fourth approach we can take is give some patient vitamin supplements, for example B12 supplements, which will help the patient. Fifth is physiotherapy. We can give patients sticks. Sticks are given the patient and they put in their mouth, and they keep increasing the number of sticks, which basically helps to loosen the bands and helps the patient to have a better mouth opening as compared to before. And you can also give some heat therapy because that helps the patient relax their muscles, which can help in mouth opening. And then finally, if all of these treatments are not effective in the patient, we go for surgery. Surgery is basically excision of all the bands around the oral cavity where OSF is present, and then on the band, since that creates a defect, that defect can be replaced with a graft. For example, pectoralis major graft can be placed over the oral cavity. And recently some new treatment have been introduced, which is stem cell therapy, which can help patient have a better life. Or if the patient has refractory OSF, for example, patient has been treated with surgery and still he develops or he or she develops OSF again, so we cannot do surgeries again and again, so we can give patient this stem cell therapy as well. Now, if the patient is not treated on time and the treatment has been delayed, there are some complications, and those complications are even worse than OSF itself. Now, the most important complication that occurs when the patient has OSF and the disease is left untreated is it undergoes dysplasia. And that dysplasia is not yet cancerous. It may lead to cancer, but it's not yet cancerous. So, if still it's untreated, then it leads to oral squamous cell carcinoma, which is a cancer of the oral cavity. And then that is a very serious condition because patient's life depends on that, how you manage oral squamous cell carcinoma. Initially, if the OSF was treated on time, patient will not have developed oral squamous cell carcinoma, and this is a life-threatening condition for the patient, and it has a very less 5-year survival rate for the patient. However, if we see, the chances of OSF converting into cancer is less, but it does have malignant potential. We have to keep that in mind and to treat it as like that we have to treat OSF on time before it leads to cancer. So in this video, we talked thoroughly and in depth about everything that is related to OSF, starting off from its introduction, etiology, pathogenesis, clinical features. Then we moved on towards how do we stage it, how do we grade it, investigations, management, and then lastly we talked about complications. So I hope this video was useful for you, and if you like this video, please like, share, subscribe, and press the bell icon. Thank you for watching this video. See you next time.